Okay, welcome to an episode of the SMUG Podcast. I'm Chris Myers, and this is my colleague and friend Luke Millwood. Luke, many thanks for joining us today.
Thanks for inviting me.
No problem. So obviously I run SMUG. I get lots of emails, particularly from physiotherapists who are working in private practice that want to implement ultrasound-guided injections into their private practice. Like myself, but you have more recently been through that journey. And hopefully we can give people a bit of a flavour around the sort of training and also for you to give people some tips on that journey. So shall we start at the beginning and just find out a little bit about your qualifications and how you've gone from being a physiotherapist to somebody who's implemented guided injections?
Yeah, sure. So I've been a physio since 2007, and I've been predominantly in musculoskeletal physio since about 2009. Yep. I've been working privately from about 2011. Throughout that whole period, you're in musculoskeletal physio, and you're diagnosing to the best you can with a set of skills that aren't necessarily that specific. And so I found myself getting a bit frustrated with not really knowing what I'm actually treating.
Yeah.
So that took me down first of all, a diagnostic ultrasound pathway. I really wanted to understand more. And luckily, I was working with yourself and some other clinicians that use it a lot privately. So I was in an environment that had access to scanners. And the first thing, you need to have access to a scanner. If you haven't got a scanner, you're a little bit stuck.
Yeah.
So what I did was I went in and sat in with other clinicians that were more experienced and at least got an idea of what a scanner looks like and what normal tissues are starting, gives you a bit of an idea.
Yeah.
And then I enrolled on a postgrad certificate in ultrasound scanning. And that gives you a really good idea of making better ideas and judgments about what you're seeing and what things might very well respond well to just continued physio.
Absolutely.
Or if you need to do an actual injection on those people.
Perfect. So stage one is getting good access to a machine,
yes.
Isn't it? And also you were, I suppose, lucky because you were in an environment where there are other people scanning, but there are lots of people that won't be in that environment and essentially are trying to do this on their own. And that's quite tricky, isn't it?
It's really tricky. And a lot of it is about losing your ego. So when you pick up a scanner, you might as well pretend you've never seen anatomy before. It's not like the books. It's completely different. And it does, for me, it really, from a point of view of looking at it, at spatial awareness was really, really challenging. So the first thing really is you've got to immerse yourself in it and pretend that you've never seen anything before. And this is the first shoulder that you've ever seen.
Start at the beginning.
Yeah, start at the beginning and just rewrite yourself as a clinician. The trick is once you've got access to the machine is that every single peripheral thing that comes through your door, you do your normal assessment and then you back it up with some scans. Yeah. Even if you tell the patient, I'm only training, but I'd like to have a scan. If I see anything I'm worried about, then I'll have a chat with someone who knows it.
And that's fine as long as you've got somebody else like myself that's next door that can go, okay, I'll come and have a look. But if you are working on your own, it really does expose you quite a lot.
You do have to be careful. If you just say to someone, now I'm going to scan your shoulder, they can be under the understanding you know a lot more than you do. Yeah. And they and you're saying things to someone that might not be true. And so it's about making sure that the patient knows your level of what you're doing. And if it's just as a teaching thing for yourself, most patients are absolutely fine with that, but you have to say that I can't diagnose with this. Yeah. This is something I might have to send you off to see someone else.
Yeah,
and go from there.
And certainly if you've got a patient that's had an MRI scan or, has had, surgery or somebody's looked at it and you've got a report, then obviously that's quite a good patient to scan because you've got an idea of what you're going to find, and that can be quite helpful. So we get lots of people that email us and go, well, we want to start ultrasound guided injections. And my first question is, well, can you scan? And they say, oh no, I haven't started that yet either. And I think there's a bit of I think some people will think, well, I don't want to learn how to scan. I just want to do ultrasound guided injections. And that just doesn't happen, does it?
You've got to ask yourself why you want it.
Yeah.
Because being able to scan without even doing an injection is a lifelong difference in your clinical skills and your ability to, and I've qualified as a musculoskeletal sonographer about 6-7 years ago, and I only feel now that I'm just dipping below the surface level. And so you have to commit for long-term changes, and you have to commit to educating yourself constantly.
Yeah.
So then being able to hold a picture, an image of what you're seeing nicely, and hold that in place.
As in to hold it nice and still whilst you're doing an injection.
And then you've got to be an octopus and use your other hand to be able to do whatever you need to do, setting your parameters and injecting. With a patient who might be feeling it's uncomfortable or painful, and you're dealing with that psychosocial side of things. Yeah. You've got lots of things in the air. So you do have to ask yourself, why do I want to do this? Yeah. This is going to change my clinical career going forwards. You can't go in half-mastered this. It's something that you need to throw yourself into.
And also the whole idea of, well, I don't want to scan, I just want to do a guided injection. The whole idea, or the way you're going to get the best results for a guided injection, is because you've got a good diagnosis, and clinical assessment is limited, isn't it? Absolutely. With what we can actually diagnose. So I think the one of the main messages is that if you want to do guided injections, get access to a machine, and you need to then start learning how to scan. That is stage one, and the better you are at scanning, the quicker you pick up guided injection.
Yeah, absolutely. So when you've done your postgrad certificate, typically you're looking at about 250 scans to pass. Yeah, which is enough to make you think you can see some normal anatomy on your friends or your family that don't have pathology. I remember when I qualified and I thought, okay, I know what I'm doing now, and then you put your probe on the first elderly full rotator cuff tear, and it looks completely different. And if you can't find your landmarks and you haven't got confidence and patient mileage under you, good luck sticking a needle in that. You've got to know the target that you're aiming for. So, injections are really around people that have pathology, or you might have a person who's got an arthritic hip but is a bigger obese patient, and so you're having to understand what you're seeing on another level than you do from just scanning. So it's about building blocks.
So you did your postgraduate in musculoskeletal ultrasound. How long after that did you start your injection training, and what course did you do?
So when I qualified for my sonography, there wasn't an individual ultrasound guided course that you could do. So I went back to university and did a non-guided, landmark guided injection course. Yeah. And then that gave me the ability then to kind of like mix and match the two. Yeah. I predominantly worked in private practice, but that means that you don't have access to patients that will let you inject them. If you say, this is the first time I've injected, you don't mind if I inject you here?
And also as a clinic owner, I want people to be injecting our clinic that have done hundreds and hundreds. So it was very hard, wasn't it, to give you patients to inject. In fact, you didn't do it. You went on and got a NHS job.
Yeah, absolutely. So through contacts, I managed to job share with a colleague of mine who could just go part-time. So I managed to get them to do an extended scope role in the NHS, which was basically really like scanning people and sending people for MRIs. So I had a machine just like this, and I had free run effectively to be able to scan and inject appropriate patients under the banner of the safety of an NHS.
And it is different, isn't it? I mean, we work just in private practice now. I worked for 10 years injecting in the NHS, and I always use this phrase, but when you work in private practice, you feel very, very exposed to, let's not be blunt about it, complaints, people suing you. Yeah. When I worked in the NHS, I never felt like that. I just felt like I had this beautiful cotton wool sort of ball around me, and I was a bit untouchable, which probably in hindsight was a bit naive. But when you start injecting in private practice, it just feels like such a different ballgame.
Well, in the NHS, patients don't have your direct email. Yeah. They go through a complaints procedure. Yeah. It might never get back to you. Yeah. You don't know, but
they can't contact you the next day and go, it's still sore.
A flare up. Yeah. Whereas in private practice, they've got direct access to you, so you know which injections work well. You know which ones flare up. You know which ones that you don't really like to inject because they don't work very well. Yeah. And also you do have the ability to contact patients. So I make it a rule that everyone at about a month after an injection gets an email from me to see how they're doing. Yeah. So that helps with the patient journey and patient experiences and expectations. Yeah. but it also makes you know which injections work well, and you can pass that back on to your following.
And I think the key thing you said there is expectations. We all know that, obviously in private practice, people are paying £250, £300 for an injection. And you can look them in the eye and say, this may not work. We all know steroid injections will be very effective, but we also know they cannot help some people. And you tell somebody, look, yeah, there's a 70% chance this will help, or there's a chance it won't help. But actually, it does make it more difficult when they're paying, because their expectations are sometimes different. Even when you explain it, you send them patient information leaflets, they almost sometimes expect, well, it didn't work, I should get my money back. These are all things that you have to have ways and methods of dealing with.
Absolutely. You have to be really honest with yourself. Should I inject this patient? If it smells like it doesn't feel right, you have to listen to yourself. It's not worth it. But you also have the stress of the patient. Well, I've traveled 2 hours to get here.
Patients put a lot of pressure on you, don't they, sometimes, to inject.
And sometimes you need to stay true to what you think's right.
And what's best for the patient.
Absolutely.
Because they don't always know.
Yeah.
So you went to the NHS. How many injections? This is a question I get a lot. Now, I run a postgraduate certificate in ultrasound guided injections, and we have come up with a number to achieve a basic level of competency in ultrasound guided injections of 35. Now, we know that is low. That's not proficiency. That is just the basics. How many injections do you think it takes to get good at ultrasound guided injections?
Well, the first thing we say with around the 35 to pass. If you do a non-guided landmark course, it's 10.
I know, yeah.
So it's not a lot, is it? It's not a lot. You're not even getting one of each of the main injections there. And you could get a hip injection and pop into your diary. You could get carpal tunnel, the first time. We've all had that time when you've had the first one in with a real life patient. What I did is when I went back to the NHS, I had a Word document, and I documented every single injection I did.
So like a logbook.
With just some self-reflections, like you would do a CPD for your CSP membership. Documenting every single injection that I did, what I found worked, where I went wrong, what I found, panicking because the patient's panicking, and actually that's your time when you slow right down. Otherwise you're going to mess things up, and then learning from that. And I produced a big document of it, and I did 300 in that year. And then we sat down and I showed you what I've been doing. This is where I am. This is where I'm developing to. But even at that point, you're still...
Well, we still did supervised injections in the clinic after that. So absolutely. I think we say about 250. And this is where people struggle in private practice, because if you hadn't been to the NHS and you just wanted to do it private, like how long would it actually take you to do 250 if you were just starting off? It would take you years. And it's a bit like if you want to perfect your golf swing, you've got to be out a range every day. Like it's never going to change. Also the fact that when do you play golf?
No, but I just heard.
Yeah, you read it.
Yeah,
in a book.
Yeah. What also the difference between in the NHS and getting those things? You've got the safety of a PGD, so you can inject without having to be able to prescribe drugs. So I had that safety net, but I'd also qualified as an independent prescriber, so I had the ability as well to prescribe drugs. When if you're private, you really need to be an independent prescriber.
You do, don't you? Otherwise, why would somebody else take the litigation and the risk, if you like, for you? And certainly in our practice, everybody is independent prescribers, and you do learn a lot through that process as well.
Absolutely.
So you've got your 300 injections, and I know, because obviously we worked together, that you had a nice range of like shoulders, hips, knees, but it's very hard to control what's coming through the door, isn't it? And you every now and then, it probably doesn't happen anymore, but you'll get an injection where you at the beginning you've never done it before, or at least you haven't done it for a while. And we obviously work together. I always worry about people that are working on their own in practices. How they deal with that.
I still have patients when they come in, more to do not with the injection that you're doing, it's the pathology around the injection. So you'll see, I'm never getting an injection around that osteophyte that's sitting on that joint. maybe I need to do it at a different angle and get in where you might never have done it before.
Like you might have done it in plane all those years, but actually you need to do this one out.
Yeah, so you have to think outside the box, and then you have to think, right, well, I understand the principles of doing this out plane. I've just never done this one out.
Yeah.
And it's having...
That comes down to the probe skills.
The probe skills.
You need to be able to adapt to those situations.
And getting yourself out of trouble when you lose the needle as well, comes down to probe skills. So being able to lock down and, if you have to put your forearm on the patient to hold that probe on the plate. Yeah. So you're only moving one thing, otherwise you start moving everything and it all goes wrong. But also having access to be able to phone up. So, I'll have a patient that comes in and something pops up in their patient
information, because we get a screen number for them. That sounds...
I'm a bit worried about that. I'll be able to phone myself, or if you're not around, one of the other doctors we work with, for instance, to say, look, I've got this patient coming. He's in now. I've just pulled something out of this joint.
You had one recently where you took a load of blood off a knee that you didn't expect. And these things happen.
Yeah, and you think, what do I do here?
Yeah. And I think that's the biggest thing that I, over the years, have thought. We're so lucky that we're in an environment where we've got people to bounce ideas off, support us, and I think you really need that. So actually, if you look at your journey, and often people ask me this, if you were sitting at home today saying, right, I want to do ultrasound guided injections, first of all, you've got to get a machine, you've got to do your ultrasound, you've got to get your ultrasound skills, whether that's a PG dip or mentorship or something like that. You've then got to go and do some sort of injection course, and you've got to do your independent prescriber. So I always say to people, it's probably a minimum of a 3-year process. Would you go with that?
Yeah, absolutely. And it depends how quickly you do it. Some courses are massively oversubscribed. You might want to have some time in between. So
to consolidate what you're learning, which I would certainly advise.
Absolutely. What I found was, as I started to do more getting into the injection, the techniques of the injection were starting to overtake almost my skill level of my scanning.
I remember that.
And so then you're like, right, now I'm getting a bit muddled up. So then I went back into the NHS. I got a job again through some contacts as a sonographer, just
working in radiology,
and again that really changed. And again, it's all about self-reflection, keeping the log, looking back at patients. So they went off and had an MRI. I've referred for an MRI. What did they come back with? And then you get it's easy to lose one skill when you're learning another skill, and it's about taking some time, a breather off of this one, to reinvent yourself there. And once you're at that level, I'm constantly learning.
So if you were sitting at home and you somebody said to you, which I'm sure they do, what give me some tips, Luke, because obviously you've got to a point now where you're injecting an awful lot privately, you've got excellent skill set, but it's been a long journey. If you go back to yourself at the beginning of that journey, what tips would you give yourself?
So the first one is patience. You'll burn out if you want to know it all straight away. You need to understand that this is completely different from physio. Although it's a physio skill, it's a very different skill. And it's being able to understand that and be humble and go, right, I don't know what I'm talking about here. There's so much that can go not wrong, but can be different from what you see. So patience is an important thing. Investing. So investing not only your time, but money as well. If you think this is where you want to go and you're really interested, get yourself the best machine that you can. I started off by buying a little Clarius handheld one. And although it was really good for doing the course, because you can just scan things and you've got it there and then, the quality of the image just wasn't enough to be able to go from where I was. So I just bit the bullet and I got one of these machines.
That's so spending money on the ultrasound itself, but also on your training.
Yeah, absolutely. You're going to have to take, if you've got a busy life and you've got other things going on and kids, you might have to take a day of clinic a week out, and
just to commit to the process.
To commit to the process, and that does cost money as well. But as long as you keep your focus and you say, right, for the next 3 months, I'm going to just focus on the shoulder. Not even going to bother with the ankle. Just leave that alone, and then just slowly start to build up. Get into a community like what I find really useful is the SMUG's
face group.
Excellent. There's some amazing clinicians on there, and if you've got a question, you just put it up there, and then by the end of the day you'll have loads of answers.
It's got thousands of members on there. It's a really positive group, and I mean we both upload scans. We've been doing it a long time, but we still upload scans, and we get feedback from lots of good clinicians.
Yeah.
And any others? What do you think are the other key things that have helped you get where you are now?
Knowing your limitations is really important. You put your probe on something and it's not MSK, and you need to comment on it. And you need to say, well, this falls out of my remit.
How do you get? That's what I'm trying to get at. How do you get that skill? How do you know when you're out of your remit? Like, how do you?
It's education and patient mileage.
Yeah,
you need to get that patient mileage in, and you've got to say, that thing doesn't look right in that tissue. That's not what I've seen before.
And the radiology would have helped that.
Yeah, radiology would help.
The NHS.
But also, just going and just asking other people, just knock on the door, saying, look, what do you reckon about this? It's a bit weird, isn't it? Being able to be humble, and you're not an island. You can't grow yourself.
No. And would you put people off doing it?
No. If I didn't scan, I'd probably be pretty bored as a clinician. I don't think I could stay.
So it's given you that longevity in your career. Because you are, you're quite young looking, but you're actually older than you have. No, I agree, and that's the same for me. I worry that if I hadn't started ultrasound and doing all the injections, and I don't know if I could have just kept going for another 10, 20 years, because I'd felt a bit flat. If that makes sense.
The other thing to be aware of is patient management is very different. You can treat a patient with physio for 2 months, hardly make a difference, and they still think you're good. It's fine. If you meet them for 25 minutes, you do an injection and it doesn't work, you're the worst thing. And
that's even with trying to manage their expectations, isn't it?
With providing the information, saying that for this, I don't think it's going to work for you. We could try it. They still were like, if it doesn't work for them, then they still get cross.
And the other thing I would add, and obviously I do loads of teaching, and people will say to me, I don't have the patience to scan, not the patience as in the actual clients to scan, or I just don't get the patients that I need that have peripheral joint problems. I just see loads of spinal. And my first thing is exactly. You've got to change the environment you're in, because there's no point committing all that money, committing all that time, and essentially not having the correct type of patients to scan in your clinic. And the other thing, and I know we talk about this, you massively de-skill in other areas, don't you? Because you're upskilling in something that takes quite a lot of time.
Yeah, you've got to be happy to drop stuff. I am no good at backs now.
Because you don't see them.
Because I don't see them. And when I get one in, I'm like, what do I, so you've got to be thinking. So you've got to decide if you want to scan and you want to do injections and you're a peripheral person.
And you've got to commit and be prepared to let other things drop a bit in terms of your skill set.
Absolutely.
Well, thank you very much, Luke.
No problems. Thank you.